The webinar is entitled COVID-19, the role and responsibility of the caregiver and the clinical engineers in the fight against this pandemic. I wish to use this opportunity to thank all our partners, the Ghana Health Services, and especially our lead presenter from Ghana Health Services, Mr. John Ziena, the Canadian Biomedical Society, the CMBES, and Bill Gentles, as well as Martin, who will be leading the presentation. Ghana Medical Help is an international charitable organization, and we, since establishment in 2010, we've been working to transform the health services and sustainably improve health outcomes for more, especially the underserved and impoverished communities in Ghana. Our catchment area happens to be the Upper East and the Upper West regions of Ghana. We've had a series of projects, starting with our hospital project, where we essentially donate medical items to these rural hospitals to help in this service delivery. We improved upon that by getting representatives in the various hospitals and added on clinical engineers in all our partner hospitals, so that then the equipment that are donated can be used appropriately, and when they are faulty, we don't need to pack them up. It is through these interventions and programs that we formed an annual meeting of the clinical engineers, and through that we did apply for a grant to organize one of our annual workshops, including the clinical engineers and provision of toolkits for them. And of course, due to the pandemic, we could not have this done physically as in the practical bit of it. And as such, we retailored our focus to look and address the COVID-19 issue, and then continue with our other online clinical engineer workshops, awaiting when this pandemic is controlled, and then we can go ahead with the practical bit of it. Once again, I thank you all for joining us today, and I thank our leaders for today from the Ghana Health Services, the CMBES, and my own founder, Kelly Hartfield, who is hosting this meeting. And we are so much grateful that everyone here has made the time to join us. And I can assure you that this would be to the benefit of all of us, and will go a long way in helping us control this pandemic.
Thank you, Dominic. Bill Gentles here. I'm chair of the International Outreach Committee of the Canadian Medical and Biological Engineering Society, and I've been working with Kelly and Ghana Medical Help for the last 5 years or so. It's a great pleasure to be here today, and I'll just ask my colleague, who is about 3,000 miles away from me, Martin Poulin, to introduce himself before we start the webinar. Martin, over to you.
Good morning, everyone, or good evening over there. I'm Martin Poulin, and I'm the Director of Biomedical Engineering for Island Health, which is on Vancouver Island, the very west coast of Canada. And I'm also a member of the Outreach Committee of CMBES, and also very pleased to be here.
Thank you, Martin. Okay, without further ado, we'll get into this. Now, I'm going to be presenting the first 2 sections of this webinar, then John Ziena will jump in and present 2 sections, and Martin will present the final 2 sections. So without further ado, now on to the meat of the webinar. I'm going to talk about, in section 1, what is COVID-19 and why is it such a problem? What are the planning issues when setting up a COVID ward in an existing unit? What are the most critical items of equipment to manage COVID-19 patients? And what are the different types of PPE that are used, and what situations should they be used? What are the best practices for clinical engineers when entering and working in a COVID-19 patient area? And finally, what are the recommended precautions for clinical engineers when working on equipment that has been used in a patient with COVID-19, including decontamination procedures? So we've got a lot to cover, and I'm going to start now with a little bit of a talk about what is COVID-19 and why is it such a problem. Some of these illustrations are from an issue of the New York Times that was published in March of 2020. There's a lot of information on the internet about COVID-19, some of it more reliable than others. So we recommend that you stick to reliable sources if you're looking up information. Avoid the information on social media. So New York Times published some very nice clear drawings. The coronavirus is named after the crown-like spikes that protrude from its surface. These spikes are proteins, and the coronavirus is enveloped in an oily bubble or a lipid molecules, and these molecules are the weak point of the virus, which I'll talk about a bit more later. These molecules can be destroyed by soap or alcohol, and that's the weak point of this virus. The virus enters the body through the nose, mouth, or eyes, and then attaches to cells in the airway that produce a protein called ACE2. The virus is believed to originate in bats, where it may have attached to a similar protein. So the protein spikes on the virus attach to proteins in the tissues in the airway and then begin to enter the body. The virus infects the cell by fusing its oily membrane with the membrane of the cell. Once inside the cell, the coronavirus releases a snippet of genetic material called RNA. Now, the infected cell has a manufacturing facility in its nucleus where it can make copies of itself. The infected cell, so it reads the RNA of the virus and begins making copies of the virus that will have several functions, keeping the immune system at bay and helping to assemble new copies of the virus. I should just, as a side comment, antibiotics will kill bacteria, but they do not work. They're ineffective against viruses. So taking antibiotics is of no help in fighting this virus. So the manufacturing machinery in the cell begins to churn out new spikes and other proteins to form copies of the coronavirus. New copies of the virus are assembled and carried to the outer edges of the cell. And here's the copy of the virus releasing copies of itself out into the bloodstream. So the illustration on the right is a schematic diagram showing virus molecules leaving a cell and being circulated in bodily fluids. The left-hand illustration is an electron microscope photograph of a cell excreting virus particles into the body. And these can be manufactured in large numbers. These yellow spheres are all virus molecules. These can be manufactured in large numbers by a cell and quickly invade the body. So most COVID-19 infections cause a fever as the immune system fights to clear the virus. But in severe cases, the immune system can overreact and start attacking lung cells. So as a result, the lungs will become obstructed with fluid and dying cells, making it difficult to breathe. So coughing and sneezing can expel virus-filled droplets onto nearby people and surfaces. And this is the most common mode of transmission of the virus, is through droplets. People can be contagious even before they realize that they are infected. And that's one of the big challenges in controlling this virus, is that people without symptoms may still be spreading the infection. So the WHO, the World Health Organization, recommends that people diagnosed with COVID-19 wear masks to reduce the release of viruses. As a general rule, when coughing or sneezing, cough into your elbow or a tissue, not into your hand. The virus is more contagious than many common diseases such as colds or flu. And so it's much more important to take precautions against this virus. Now, soap or alcohol disinfectants can destroy the virus. when the soap molecules wedge themselves into the lipid membrane surrounding the virus, they pry it apart, causing the virus to die. The best way to avoid getting infected with the coronavirus is to wash your hands with soap or an alcohol hand wash. Avoid touching your face. Keep your distance from sick people and regularly clean frequently used surfaces. Now here's just a schematic drawing that illustrates the weak point of this virus. So, and it illustrates infectious agents that are more resistant to disinfectants and least resistant to disinfectants. So the most resistant infectious agents are bacterial spores. They're the hardest to clean. As we move down this list, each of these agents is easier and easier to clean with a disinfectant. At the bottom of the list, we have enveloped viruses. The coronavirus is considered an enveloped virus, and so it is the least resistant of all the infectious agents to disinfectants or soap. And that is the weak point of the virus and the best way we have of controlling it at this point in time, as we currently have no successful treatments and no vaccines that can fight the virus. So the only thing we have to fight the virus at this point basically is soap and water. So a question many people ask, how long does the virus survive on surfaces? So if someone sneezes or coughs and their droplets land on a surface, they may stay active on that surface for over 24 hours. And if someone else touches that surface and then touches their face, they may then become infected with the virus. So in this, in the three sketch graphs, which are reproduced from the New England Journal of Medicine, it's shown that the virus will survive on a cardboard surface for up to 24 hours. This shows the decreasing density of the virus or survival of the virus. After 24 hours, it's pretty well all gone. On stainless steel surfaces, which many medical devices have stainless steel surfaces, it lasts up to 48 hours before the virus is essentially dead. But plastic surfaces last even longer. The virus can last up to 72 hours on a plastic surface. So that's why it's important to be constantly cleaning surfaces that are touched frequently. So just talk about some of the symptoms of COVID-19. They include fever, tiredness and dry cough, aches and pains, nasal congestion, runny nose, sore throat. They may include digestive issues such as diarrhea, but there are some less common symptoms that may also be an indication of the coronavirus. And some of these are loss of the sense of taste or smell, sudden confusion or an inability to wake up and to be alert. This may be a serious sign that emergency care is needed. Also, people with a fever, cough, and difficulty breathing should seek immediate medical attention. Now, I should say that most people, about 80% of the people who are infected, recover from the disease without needing special treatment. But they're still infectious while they are having an insignificant number of symptoms. But older people and those with underlying medical problems like high blood pressure, heart problems, or diabetes are more likely to develop serious illness. So these are some World Health Organization recommendations to prevent infection and slow the transmission of COVID-19. 1, wash your hands regularly with soap and water or clean them with an alcohol-based hand rub. Anytime you've been outside, traveling on public transit, or in an area where there may be people who've touched surfaces and may be transmitting the infection, you should wash your hands when you return to a facility where that's possible. Number 2, maintain at least a 2-meter distance between you and people who are coughing or sneezing. Number 3, avoid touching your face. And this is one of the most difficult precautions, but this is the way you can pick up the virus after you've touched a surface that's carried the infection. Number 4, cover your mouth and nose when coughing or sneezing. Number 5, cough into your elbow or a tissue, not into your hand. Number 6, stay at home if you feel unwell. This is the most common way the virus is transmitted, from people who feel unwell and yet go out into public. Again, refrain from smoking and other activities that weaken the lungs. And finally, practice physical distancing by avoiding unnecessary travel and staying away from large groups of people. Moving on. There are a range of resource requirements or medical equipment requirements required to treat different levels of severity of the disease. So if you have a mild case of the disease or a moderate case, simple isolation is an effective treatment to limit your exposure to other people. And as I said before, 80% of the population will recover spontaneously. However, if you begin to develop severe symptoms, oxygen therapy will be required if you're having difficulty breathing. And this may progress to a critical stage where you'll require mechanical ventilation. And those are a small number of cases where the virus becomes lethal. And the percentage of cases that can lead to death is varying as we collect more data. It's anywhere from 1% to 5% of cases are found to be lethal, depending on which study you read. John was going to talk about some of the planning issues when setting up a COVID ward. And this is just an illustration, a schematic illustration of a typical COVID ward as recommended by the World Health Organization. And there are a number of points to make in this illustration. And some of the areas in the illustration are numbered, but the numbers are a little hard to read, so I'll point to them with my cursor. So number 1, outside each patient room, there is an alcove where you can take off your PPE before you move into the clean area. So this is a clean area that only staff can enter. No patients are allowed into this central clean area. And if a staff member has been working in a patient room, they should then remove their PPE, personal protective equipment, in the alcove just outside the patient room. Number 2 is the patient room. So these patient rooms are around the perimeter of the clean staff area. And so infected patients are kept separate from the clean staff area. Number 3, each patient has their own toilet facilities, which only the individual patients can enter. Number 4, over here is a PPE storage area. It's part of the clean area where staff can take out PPE and put them on before they enter the patient room. Number 5 is the staff workstation. So patients would enter their rooms from an exterior door where they can enter the room without traveling through the staff area. So there are 2 directions or paths of travel. Staff travel into the COVID ward through a separate staff entrance, and patients enter through separate patient entrances. A simpler patient critical ward might look like this if it's set up in a tent, and there'd be a separate entrance for each patient and a separate toilet for each patient. Then again, if you're setting up tent facilities, there'd be separate pathways for the staff to enter, the green arrow, and patients to enter, the yellow arrow up at the top here. And fencing to separate staff and patient travel from visitors or the general public. So you want to control the movement of infectious patients as well as non-infected staff. And presumably staff are going to be screened as they enter this to assure that no staff who are infected are working in the clean area. This is just an illustration of one possible layout of these staff are sitting in the clean staff area, and there's a window into the patient's room, and through extending tubing and cabling, they have moved the oxygen concentrator and the patient monitor outside the patient room. So there's work here for clinical engineers to extend these tubings, extend the cabling, so that staff do not have to interact with some of the medical equipment by going into the patient room. They can stay in the clean area and still adjust the settings of the monitor or the oxygen concentrator. Question from George Boadu: is it advisable for more COVID patients to be kept in one ward? Can you keep 10 patients in a ward? Yes, you can. It's advisable, if possible, to have them in separate rooms, but if that is not feasible, again, you still need to have precautions to separate the clean areas for staff and the entrances for patients. Moving on to the next slide. Now, just some electrical requirements of these, SARI stands for Severe Acute Respiratory Infections Center. Each building of one of these COVID wards must be equipped with a ground earth component. The green wire here would go to the ground point in the electrical panel for the COVID ward. The connection must be accessible and protected against corrosion. It's a spike into the ground which provides a common ground point for all the electrical circuits in the COVID ward. Just a brief mention of ventilation. In many COVID wards in Ghana, you may not have negative pressure rooms. You may only have ventilation through an open window in the patient room. This may not be able to achieve sufficient changes per hour if there's only a single window. And so you need to be aware of the fact that simply working with a single window, you may not get changes in the air. However, if you open a door into the patient room from the clean staff area and the wind is blowing in the right direction, it may blow infected particles into the clean staff area. So great caution needs to be used when entering and leaving a patient room if the window is the only form of ventilation. You need to enter quickly and close the door, leave quickly and close the door to avoid exchanges of air between the patient room and the clean areas of the ward. Now, just talk about some clinical engineering issues and responsibilities during the pandemic. Your clinical engineers will be responsible to ensure equipment is ready and available, responsible for maintaining equipment in good running order, keeping track of equipment, where is all the functioning equipment so that it can be accessed quickly when needed. There may be requirements to repurpose equipment such as anesthesia machines to allow them to be used as ventilators. But again, this requires the use of skilled staff, anesthesiologists, to actually operate this equipment. Inspection of equipment after use to ensure it's still functional and available for the next patient, and acquisition of new equipment and acceptance testing of new equipment before it's placed into use in these critical wards. Those are just some of the responsibilities of clinical engineers. Talk now about a list of equipment that is commonly used in COVID wards, and not all of this equipment may be available in all locations. So the top 4 items are the most essential in any ward that's treating a COVID patient. Thermometers to measure temperature, pulse oximeters, vital signs monitors, and oxygen concentrators, or source of oxygen such as cylinders or piped oxygen in the larger teaching facilities. Those 4 items of equipment are essential in any location that's treating COVID patients. As you get into the larger district hospitals or the teaching hospitals, you may have access to mechanical ventilators, CPAP or BiPAP units with a helmet or nasal mask. CPAP units and BiPAP are somewhat more risky than ventilators in that there is a greater possibility of droplets from the patient escaping the respiratory circuit and getting into the room air. You may have access to, and it's important to be able to do blood gas analysis to check the oxygen concentration in the patient's blood, and an autoclave, a small tabletop autoclave to re-sterilize some of the accessories. So a given hospital, as I said, may not have all of the above, but at least the first four if you're attempting to treat COVID patients. We're just going to talk now about the different types of personal protective equipment and in which situations each type should be used. Now, the most important thing for healthcare workers who are working with infectious patients is the N95 mask. This should be used when performing or working in settings where there are aerosol-generated procedures such as tracheal intubation or non-invasive ventilation. Healthcare workers should use contact and droplet precautions before entering the room of suspected or confirmed COVID-19 patients. Both the N95 and KN95 masks have the same filtering capability, but the N95 fits better. And the important thing when using either of these masks is to have an airtight seal. One of the impediments to making an airtight seal, which people like me suffer from, is any facial hair will impede the effectiveness of the N95 mask because it creates gaps which inhaled air can enter your nasal passages without going through the filtering medium. The next type of PPE is the medical or surgical mask. So healthcare workers should wear a medical mask when entering a room where patients with suspected or confirmed COVID-19 are present. Because of shortages, these masks are not recommended for the general public. They have limited effectiveness in protecting the wearer from droplets, but when used in conjunction with face shields, they are sufficient to protect healthcare workers. The next kind of mask I'll talk about is recommended for use by the general public. These are called non-medical masks, and their chief function is to protect others from the wearer. As I mentioned before, you can be infected with the COVID-19 virus without any symptoms, but still be able to spread it to others. And if the recommendation is that when you go out into public, you should wear a non-medical mask to protect others in case you have the virus. And these can be made out of any fabric material, a double layer of a t-shirt material or other cloth. So there are many patterns on the internet that enable you to make a simple non-medical mask without depleting the supply of the medical masks, which are in short supply and needed by healthcare workers. The disposable hospital gown should be used when performing or working in settings where aerosol-generating procedures such as tracheal intubation and non-invasive ventilation occur. The question, what is tracheal intubation? That is the procedure where the clinical staff are accessing the airway of a patient before they connect the patient to a mechanical ventilator. They're inserting a tube into the patient's throat. And during that procedure, the patient is probably coughing, and it's a rather unpleasant procedure. And so the staff, clinical staff, are highly vulnerable to being exposed to droplets. That's a very quick explanation of tracheal intubation. Now I'm going to hand it over to Martin at this point, because Martin's been doing a lot of work with face shields. Over to you, Martin.
Okay. So hello, everyone. So one of the biggest challenges during this crisis has been the shortage of personal protective equipment. With the worldwide demand and now most caregivers needing PPE, the normal sources of PPE have declined. And so we have turned to our local community and industry groups to create personal protective equipment locally. And one of the easier items to make is a face shield. And there are many devices or designs available online. But you can see a picture here of a 3D printed headband in conjunction with a plastic visor, which works quite well if you, of course, if you have a 3D printer. And again, but the difficulty, of course, is obtaining the clear plastic material, which is now also in demand. So at this early stage, I would suggest you're trying to source material as soon as you can, because the face shields are quite effective if you start to, run out of masks and other PPE. This is just another example of a face shield, but it's just using the clear material that's been cut out and using a simple headband. Now, many of these designs are open source and on the internet. And there are even simpler designs, just utilizing, I guess, A4 sized or 8.5 by 11 sized acetate that can be used as a shield and integrating it with your face mask. So there's quite a number of options online for you to take a look at, depending on the availability of obtaining that plastic in your area. And the intent is for these face shields to be disinfected between patients using the disinfectants that you can also create locally, but with the WHO or the World Health Organization guidelines. And those disinfectants are typically chlorine-based or hydrogen peroxide-based disinfectants. Surgical masks are more difficult to manufacture, so it's best to stick with the certified ones for when you're working directly with patients. But if supplies are starting to get short, some areas have been reusing unsoiled masks after letting them sit for 3 days. I mean, although there's no clear guidance, as you've seen from Bill's previous lab testing of the COVID virus, it only lasts for about 3 days on plastic. So it's just a rough guidance that there is a strong likelihood that the COVID virus will have dissipated within that time frame. So it's fairly good way of reusing the mask if needed. As Bill also noted, cloth masks are also available and easily manufactured, but you only want to use these masks to keep yourself from spreading the virus to others. They're not as effective to keep you from getting the virus. But of course, if there are no certified masks available, this would at least provide some protection. Cloth gowns could be considered as well, but then you need to worry about frequent laundering of the gowns and the handling of contaminated material. But again, something is better than nothing. Hand rub or hand sanitizer can be manufactured using alcohol. Again, WHO has some formulas that you can take a look at. And as indicated before, the disinfectants can be manufactured quite easily using chlorine or hydrogen peroxide, and the WHO has some formulas. Now, just saying, in order to conserve PPE, just some other thoughts to take into consideration, and that is for healthcare workers who are working within 2 meters of a patient, they will need to use PPE, but it's recommended that they actually stay in the area of the patient as long as they can during the balance of their shift, to reduce the need for going in and out of the room and therefore having to frequently use PPE. So one of the big conservation measures that we've implemented at our hospitals is just having the nurses just stay in the room with the patient for 4-hour shifts. And if things do progress to situations where you're extremely short of PPE, then you need to start to prioritize who actually gets the PPE. And our Ministry of Health in our area has noted the first priority is, of course, the critical care staff working with critical COVID patients. The second priority would be staff that are working again with COVID patients on cohorted units or wards. And the third priority would be those working in the emergency department and primary care workers. And then the fourth priority would be long-term care settings. So moving on to the next slide then. So I was just going to talk about the instructions for actually donning the PPE. And so if you actually need to go into a patient room, then this is the means by which you would put on PPE in order to protect yourself. Of course, the first thing is to minimize and hopefully not have to go into the room at all. And for the most part, if there was equipment that needed to be worked on, the best thing would be to have the staff inside the room thoroughly decontaminate the equipment and have it brought out of the room for you to work on. But if that's not possible, you need to go in. This is the means by which you don the PPE. So the first thing is to ensure that you have the PPE within your reach. And then the first thing you need to do is perform hand hygiene, either with soap and water or with a hand sanitizer rub. And hand hygiene, just to reemphasize, requires a good 20 seconds of, rubbing your hands extensively. And then you need to put on your gown, and by pulling the neck strap over your head. Next slide. And then you need to secure the gown at your waist to the side with the ties. The next step would be to put on the surgical mask and then the face shield. They just indicated, you would secure the surgical mask with the ear loops and making sure that it completely covers your nose and mouth and sits under your chin, and as Bill is indicating, nice and tight around your face. Next slide. So now that you've touched your face and your head, though, you have to do hand hygiene again, another 20 seconds worth of rubbing your hands. And then once you've completed that, then you can put on your gloves. And then when you put on your gloves, you want to ensure that it completely covers your wrist and sits on the actual gown so that there's no skin showing. Okay. So then you can safely enter the room. Next slide. So the next process is if you have been in the room and you need to leave the room. The first thing, if you've actually brought tools into the room, it's important that you disinfect those tools before you, of course, remove them from the room. So even before you doff or remove the personal protective equipment. So to actually remove the PPE, the first thing is to untie the side of the gown. And this is the tricky part. You have to cross your arms, you have to grab the outside of the gown and roll it forward, breaking the strap, if there is one, avoiding touching your skin, rolling it into a ball so you're only touching the inside of the gown. And as I've indicated here, you grab the exposed side of the sleeve and the glove in one arm to remove one side, and then you do the same with the other, and continuing to ensure that you're only touching the inside of the gown. And you roll it up into a little ball, and then you discard it into an appropriate biohazard container. And then you do hand hygiene again, washing with soap and water a good 20 seconds, or with the hand sanitizer or hand rub. And then once you've completed that, then you can remove the actual surgical mask and face shield. So you would remove the face shield first. I mean, this particular image shows an integral face shield, but typically we actually just use a complete face shield. So you remove that, make sure you don't touch the outside surfaces of the mask and or the face shield, and put them into the biohazard container. And then the last thing, wash your hands again. And that's the best way to keep yourself safe. Next slide then, Bill, or whatever. Okay, so just want to talk about cleaning and decontamination of medical devices for confirmed cases of, rare emerging pathogens like COVID. And just wanted to first of all state that the first thing that should be done is the actual before we even do the cleaning, is the actual preparation of the room, is to try to reduce the risk of contamination of equipment by placing the equipment as far away from the patient as you can within the room. And then if possible, to place disposable bags or covers over the device so that any droplets that are expelled from the patient land on those disposable items that can be thrown in the garbage when the patient has left the room. However, if you do need to clean and decontaminate the equipment, and or whoever does the cleaning, the first thing, of course, before entering the room is to ensure you have put on your personal protective equipment. And then once you're in the room, the first thing you would do would remove all the disposable patient connections and dispose of them into the biohazard containers. Then you would make sure you disconnect the equipment from power. And then using a disinfectant, you would wipe down all the exterior surfaces and cables and reusable accessories with a disinfectant. And you want to ensure that all visible contamination is removed, any bodily fluids that are on the devices. Now you do want to make sure that as you're cleaning, that none of the disinfectant actually enters the device. So you just need to be careful that your wipes that you're using are not too wet. If it's a wheeled device, you also want to make sure you wipe down the wheels completely. And what's important is just let it, don't towel it down, just let it air dry, okay? And then cover the device, label it as contaminated, and remove it from the room for transport to a designated area for further cleaning. Then you would then, of course, remove your PPE when you leave the room. Then the second stage is actually a second cleaning, what they call here the intermediate level of disinfection, number 2. And so once you're in your designated area for further cleaning, again, you would don your PPE, or whoever is doing the cleaning would don the PPE, remove the cover from the device, and remove and discard any air filters in the equipment and place that into the biohazardous waste. And then just like when you were within the room, you would wipe down all the exterior surfaces and cables and reusable accessories again with a disinfectant, and allow it to air dry. I just a comment, just so you're aware, in our hospitals, that 2-stage process of cleaning is currently actually being done in the room. So they wipe down physical contamination, let it dry, and then they do a second wipe down. So typically in our hospitals, that both of those processes are being done in the same area. And but the more formal and safer route would be actually to remove it to a separate area for a secondary cleaning. Now, the third note here talks about disassembly. And you need to use some judgment here. If you think some bodily fluids have contaminated the interior of the device, or then the device maybe needs to be repaired, disassembly may be required, but you need to use your judgment. I've just noted here that our hospital, we've rarely had to actually disassemble the equipment. They keep the equipment far enough away from the patient that there isn't any gross contamination to be worried about. But if disassembly is required, again, you need to ensure you don your PPE, remove the covers, and inspect for any visible contamination. If there is any sign of contamination on any of the electronic circuitry, I mean, you have to do your best to clean it. And again, as COVID is typically, it lasts only 3 days on a plastic material, I would suggest leaving the equipment to just sit for that period of time to minimize the likelihood of it remaining on the equipment if you're not able to do a thorough clean at that time. Then, but if not, you want to just continue to wipe down the interior surfaces with disinfectant, again, while being careful not to get the disinfectant on any of the electronic circuitry. And you know, do any repairs that you need to do on the device and reassemble it. Again, you want to ensure that any tools that you've used are disinfected, and that the area around where the device was being cleaned are also disinfected. And then you can remove your PPE, retest the device, and put it back into service.
Just now summarizing, there were 6 sections to this webinar. What is COVID-19? What are the planning issues? What are the most critical items of equipment? What are the different types of PPE? What are the best practices for clinical engineers? And what are the recommended precautions for clinical engineers? So those were the 6 sections of the webinar, just to summarize them for you. These are some references which also are listed at the top of your chat screen. If you scroll to the very top, you can copy and paste these references. We would like you at the end to access this link to give us a brief survey. It's only got a few questions on it. It will only take you 5 minutes, but we'll ask you to fill out that survey. But so we're going to work back to some of the questions that people have put in the chat window. There was a question from Alfred. How are we treating the air from the COVID-19 center before letting it out? Now, maybe if John is not able to hear us, can Dominic answer that question?
Oh, so really for our COVID ward or our COVID center that we have in my hospital, really we're not having sort of an airtight medium, because like you rightly said yourself in the presentation, this is mainly through aerosols or droplet infections. And as such, if you are at a distance, usually more than just a arm stretch or about 2 meters away, you shouldn't be able to, it shouldn't pose any significant risk to you. So we don't treat the air before it gets to the outside. Unlike maybe if you probably thinking of any of the diseases that, like the WHO did indicate itself, the duration of time for the aerosols to be in the air is just about 15 minutes maximum of an hour. And as such, we do not treat the air before it gets outside. Our rooms are not airtight. We essentially just practice the various preventive measures, the regular hand washing, and then the use of the 70% alcohol-based hand sanitizers. And of course, when we get in touch with the patients, then we would wear the N95 as well as the overall or coverall before we attend to them. But for the air, my center, we do not do that. And I've not actually seen any being done at any of the centers, really.
Thank you, Dominic. Moving on to the next question. Acquired infections on the job and even mortalities among doctors and nurses have been widely reported. Have clinical engineers suffered the same fate? I'll just comment briefly, and I'll ask Martin also to jump in. But I was talking to a colleague in Canada who had one of his staff test positive for COVID-19. unfortunately, the requirement is then that all people who have worked closely with that staff member need to go into quarantine until they're tested. He had to send 15 of his staff home to quarantine until their test results came back. So some staffing practices that are recommended for clinical engineers are that if you have a team of more than one, you should perhaps stagger the shifts so that they don't, or they keep their distance from each other. And some people are not even working at the same time as others, so that if one of your staff becomes infected, they pass it on to as few of your other staff as possible, because clinical engineering departments typically don't have a lot of staff to spare. And if one person becomes sick, it seriously impairs the service that you can deliver. And if one person has been close to other members of your staff, you may have to send everyone home to quarantine until they've all been tested. So with that comment, I'll ask Martin to jump in and perhaps comment on his thoughts on that matter.
Yeah, so I'm aware of that situation in Ontario. No, I'm not aware of any clinical engineers at this time, certainly within, I think even within North American colleagues, I've not heard of anyone getting infected. We have the fortunate, as I was indicating, typically we don't have to go into a COVID patient room, so our risk is quite low. And typically the equipment is double cleaned before it leaves the room. So again, our risk of infection is quite low. There was a question at the very top that asked about, is it safe to use a cloth nose mask? And just to clarify again, that the cloth mask is not preferred. It could be used as an adjunct if you did not have a proper mask, but it really only protects you from spreading the COVID virus to someone else. It does not necessarily protect you from getting the actual virus.
There's another question here from Jennifer. Is it advisable to reuse the N95 mask after wash and disinfecting it? Martin, I'll ask you to.
So there is an effort right now to figure out how to disinfect N95 masks, and there are some qualified sterilization procedures using ultraviolet radiation, and also utilizing N-type oxide sterilization. And they've also explored hydrogen peroxide plasma sterilizers to actually clean the masks. But there's a lot of work being done to try to figure out how to safely and confidently disinfect and sterilize the masks so that they can be reused. But with the exception of the hydrogen peroxide plasma and ethylene oxide sterilization, those are the only two qualified disinfectant procedures right now. But there's a lot of work being done, and I'm sure there will be other validated mechanisms to sterilize masks as we progress through this crisis. Do you want me to answer Jennifer's question?
Sure. How long can you wear the surgical mask?
Right. So there has been an active policy in our organization to encourage staff that are just working with the regular patient population to keep their masks, utilize their masks for the full day. And there is some guidance around that, but it is typically focused around one, minimize the times that you take it off and put it back on. But if you're going to do that, making sure, again, you don't touch the outside of the mask and that you wash your hands every time you take it off and put it back on again. And but if it's soiled or if it's wet, then it should be discarded.
And there's a question here from John Ziena. Are there specific recommended disinfectants to be used to disinfect equipment that's been used on COVID-19 patients?
Yes, so the WHO has prescribed some intermediate level disinfectants, but very briefly, the main components is a 1 part to 50 part chlorine to water, and the other is 0.5% hydrogen peroxide solution as well. But best to look at the WHO because they have some guidance in that respect in terms of the disinfectants recommended.
Yeah, and we've got links to their documents in the comments, and we'll circulate those. There's a question here, and I think this is important because they're from Infinix. Are there specific medications and other supplements for treatment and support for COVID-19 patients since there is no vaccine yet? There's a lot of misinformation on the internet, and I'll actually hand this over to Dominic, but there is no acceptable treatment yet for the virus. There are a lot of quack cures on the internet. The President of the United States has talked about a couple of them, and they've both been downplayed by doctors as being ineffective. The malaria vaccine is ineffective. The President was talking about injecting yourself with disinfectants. That is a highly toxic, totally ineffective. Don't do that. Also, on the social media, there's been talk about drinking bleach solutions. Don't do that. It'll destroy your stomach. Just go to the WHO website to look for progress. They're working on, maybe I should hand this over to Dominic now. Dominic, any comments?
Yeah, Bill, I agree 100% with you. No drinking of bleach, no the injection of 70% alcohol or anything of the sort. So currently there's no proven definitive treatment for COVID-19. Trials have been done with a lot of the medications that were earlier suggested, medicines like hydroxychloroquine, combination of hydroxychloroquine with azithromycin, and some antivirals, but none has been definite proof that it cures it. Currently, there are some antivirals that are being used for treatment, but like I said, it's more of a humanitarian basis that these are being done. And like she rightly mentioned, there's currently no vaccine. There are reports of ongoing trials in the UK and other places, but as it stands. So essentially, it's just boosting your immune system by eating well and taking more fruits, drinking a lot of water, and doing what we call symptomatic management. So if you have a fever, we'll usually give you antipyretics. And then if you're probably having a sore throat, or if you have any infection, then we'll treat you appropriately. So as it stands currently, there's no proven definitive effective treatment other than the antivirals that are being used currently on a humanitarian basis. Recently, hydroxychloroquine and chloroquine have been shown in the trials that have been done to be associated with an increased risk of fatalities. And so that is currently not something that is being propelled, unlike initially when there wasn't so much data and that was being used. So I would say that neither is supplement by way of medicines that are being sold as a way of boosting your immune system. All you just need to do is to eat appropriately, a balanced diet, taking more fruit, taking more water. And if you have the symptoms, kindly alert the COVID team or report to the nearest hospital, and then you can be managed symptomatically. Hopefully very soon we may get a headway through. But as it stands today, there's no vaccine and there's no 100% definitive treatment.
Thanks, Dominic. Hey, actually, here's another question for you. Per the news from hospitals, most COVID-19 patients put on ventilators die. Are the ventilators actually helping the fight against COVID-19? Dominic.
So like most people who require or would be put on a ventilator are those with severe symptoms, mostly with respiratory distress. And most of those who would develop these are those with comorbidities or those who are of increasing age. So usually these people may, as a result of an underlying comorbidity like uncontrolled diabetes, hypertension, a heart issue, would develop severe symptoms, and as said, you'll be put on the ventilator. The fact that you are put on a ventilator just would mean that the symptoms are quite severe, and as said, you could unfortunately go the unwanted way, that is being a fatality. There are people who probably go on the vent, and because of adequate immunity that they develop, they are able to get out of it and fight the virus by themselves. Just as I said, because there's no definitive proven vaccine or treatment for it, it's more about getting your immune system up. And it doesn't mean that if you are on a ventilator, you would die. And it doesn't mean that the ventilators are not effective. It just means that it's the very severe people who, without the ventilator, will not survive within the next 5-10 minutes, and as such are required to be put on there. And significantly, quite a number of people have been put on the ventilator. Just that, of course, once you are on the ventilator, the risk is high that we may lose you. But most people have, a good chunk of people have. Prominent one is like we had the British Prime Minister who required intensive care unit, and he's gotten out of it.
See, one question here, Bill. Is it from Emerson? Is it necessary to use hand sanitizer after washing your hands with soap and water? And the answer is no. You can use either the hand sanitizer as long as it's prescribed with the WHO guidance on the amount of ethanol in it, or using soap and water. But soap and water is the best. This one here, Bill, from Nicodemus. Intensive care physicians have complained about fogging of goggles and or face shields in the middle of interventional procedures. Is it common complaint elsewhere? And I suppose that would be a factor of how humid it is in the particular setting. But typically, I've not heard of that being a major issue. I would expect that goggles would fog up more quickly though than a face shield, because a face shield still has some air movement. But no, I have not heard of that as a complaint at this stage.
Just to, sorry, Bill, just to chip in that we are kindly reminded to fill in the survey as we even answer the questions. It will just take about between 2 to 5 minutes so that it informs us of the next topic that we would be looking at. So kindly remember, the link is being posted. We'll repost it shortly. Just click on it, and then you can put in the survey. It's just a single page of about 6 questions. And then within 2 to 5 minutes, you'll be able to do that.
There was a comment here, Bill, that maybe Dominic can answer, and that is, how effective is the use of an oxygen concentrator on a COVID patient?
Yeah, so with regards to oxygen delivery, ideal situation regards any respiratory illness would be to use the cylinder, because that one delivers a higher concentration of the oxygen. But where the cylinders are lacking, or where we do not have a refill of it, then in the dire emergency case, you may use the oxygen concentrator. It's better than not having, especially for the severe patients. Only issue with regards to the either the cylinder or the concentrator that we must be careful of is after it's been used on that patient, you sanitize all the equipment that are used with the concentrator. those that are needed to be disposed of, like the face mask and all that, they can be disposed of. But
I see one more question we perhaps haven't answered. Is it safe to perform aerosolized procedures while wearing gowns made from cloth? And I think the answer is preferably not to use cloth. It is better to use the prescribed gowns because they have a higher standard of repelling water droplets. But certainly if if you don't have the proper gowns, then certainly using cloth would be better than nothing.
Kelly, I think maybe we should wrap it up. It's now 8:30 Ghana time.
I agree. I think we talked about all the questions, and I think if you missed a question, if you missed an answer, just watch the video link. Again, we're going to post the recording of this webinar on the WhatsApp groups. If you got a WhatsApp message alerting you to this webinar, then we're part of that WhatsApp group, and we'll post the recording. Also, again, on Facebook, Ghana Medical Help. If you add our Facebook page, then again, we'll post it on there and our website. So lots of options for you to listen to the parts that you missed. Otherwise, I'll maybe let Dominic conclude things.
yeah, you're good. Okay, so thank you very much, Kelly, for the concluding remark. Just once again, thank all our partners, Ghana Health Services, and more especially Mr. John Zena, the CMBES, and Dr. Bill Gentles and Martin. We're so much grateful for this partnership, and a very special thank you to all our participants for today. It's been wonderful having all of you, and we got more than 50 people participating. And just before you exit, I would kindly remind you again to type in the link, or just tap on the link if you're using the phone that we've put up in the chat group, as well as is being displayed on the PowerPoint presentation, so that you can put in your comments so we better prepare for the next webinar. We are so much grateful for your presence and for making time to join us, for spending an amount of money to purchase data to join us. And even with the difficulty in connection, most people still stayed and went through this presentation. We're so much grateful. We'll prepare for the next webinar, and we would keep you updated on that. We'll send the link to the various platforms like you may have seen and joined for today's program. And hopefully we all learn one thing or the other to help to control this pandemic. So once again, so much grateful to our partners, the GHS, the CMBES, and Kelly, our founder, the founder of Ghana Medical Help, and all our participants who joined us today. We're so much grateful. God bless.